Hello, everyone. I'm Richard Conway, reporting for Room Now from EULAR 2022, which is in Copenhagen. I'm at the meeting virtually, so I'm coming at you from Dublin, Ireland today. And I'm here to talk to you about an abstract that was presented at the plenary abstract session on Wednesday. It was OP0070. It was from Kreibolder et al. From the Leiden early arthritis group. And one thing I've noticed about this meeting already is that the titles are extremely long. They're almost like an abstract in and of themselves. But the title of this abstract was Intervention with Methotrexate in Arthralgia at Risk for Rheumatoid Arthritis to Reduce Development of Persistent Arthritis and Its Disease Burden, a double-blind randomized controlled trial. From now on, we're going to call this study the Treat Earlier trial, which is the acronym that they put on it. So as the title would suggest, this was a randomized controlled trial. It was double-blind with placebo. It was a 2-year study. The first year of it was the treatment phase, and then there was a year observational phase after that. You might ask, what was the treatment? So the treatment was methotrexate at the maximally tolerated dose, up to 25 milligrams a week, and 1 shot of intramuscular methylprednisolone at the start of the study, 120 milligrams of that. And the group they were studying here was patients who had arthralgia, so they had joint pain. They did not have arthritis, no joint swelling. They were clinically suspected of potentially developing rheumatoid arthritis. And for more details on that, best to go and look at the previous publications of this group from Leiden, because they've done a lot of work in that area. And they also all had MRI findings of synovial inflammation. And that, of course, is important. Their MRI was not normal. So there were 236 participants in this study. The primary outcome that they were looking at was arthritis-free survival. So they essentially were seeing if methotrexate prevented rheumatoid arthritis, and it didn't. So their numbers who developed this primary outcome, so the arthritis-free survival was 80% versus 82%. There was a delay in the development of the arthritis in a higher risk subgroup, but ultimately they all ended up in the same place. So far, so boring. In many ways, we've seen similar things like this before with other studies, that you can potentially delay things by intervention, but not really prevent it. But it got a lot more interesting when they looked at some of their secondary outcome measures. So they found a sustained benefit of this early period of methotrexate on outcomes. So they found it kind of across their secondary outcome measures. So on physical function in terms of HAC, on MRI changes long-term, and on pain and morning stiffness. So this is really interesting. This suggests to me that, similar to the window of opportunity we know exists in what we call rheumatoid arthritis, when we make a clinical diagnosis of that in this pre-arthritis phase, there is also a corresponding, and maybe, who knows, more important earlier window of opportunity, where intervening very early can lead to sustained, long-term, perhaps lifelong benefits that are missed and lost if you delay starting methotrexate. So this is really exciting to me. I've been a kind of naysayer in this area, the ARIA study of abatacept and the PRAIRIE study of rituximab. I was not terribly impressed by those, but I think there's a lot more here. And I think these authors have both proven a reason to do this, and they've also kind of given us a hypothesis or an explanation for why it makes rational sense and why methotrexate might work in this setting. So I'm excited. I think this is going to lead to a lot more studies, a lot more research in this area, and I'm excited to see where we get to. And perhaps in 5-10 years' time, we'll be treating patients a lot earlier than we do now. So for more updates from EULAR 2022, please tune into Room Now across our platforms, and follow me on Twitter at Richard P. A. Conway.